So good afternoon, everyone. And it's really a great pleasure to welcome you all to our instruction course on managing medical emergencies in eye centers and how to save life and practice. So we have this instruction course designed specifically for eye care centers who are small centers caring for only ophthalmology, subspecialty and super specialty, dealing with large number of elderly patients and vulnerable age group and with high risk status. So we all know many of our eye centers are under-equipped and not prepared to handle them. So this course is specifically designed to focus on some important aspect of managing medical emergencies in eye centers. So we have the esteemed faculty with us, myself, Dr. Nirmal Fredrick, Chief Instructor for this course, and also have Dr. Niranjan Karthik, who will be talking to us about how to assess a patient plan for daycare surgery. Then we have Dr. S. Jayandan, who will be talking about equipment and training required, and NABH standards, which prescribe few standards and standard operating procedure to tackle the medical emergencies that will be dealt by my friend Dr. Senthil, and also have some case studies and videos, and also in case the hospital experiences some crisis because of that, how to tackle that. So this is the overall construction of the instruction course. I'm happy to have you all here. I think people are searching for the hall, and so whoever has joined us, thank you all for joining us today, and we'll start the session right now. Yeah, thank you. So this is my disclaimer, no financial interest. And as I said earlier, medical emergencies are rare medical events, so that may occur unexpectedly. And if encountered, these events require immediate diagnosis and management. And most of us are not ready for the surprises. And as a medical professional, we also need to be aware of the risk and be prepared for the surprises. So many of us are small eye centers, and so this is my assessment of over 150 eye hospitals. We feel that the centers are not well prepared for the risk, particularly the medical risk. So if there are crash cart, they are non-functioning, they might have few expired medicines, and no MOU with ambulance, so there is no transfer mechanism for the patients. And the team is not prepared, so either a single doctor or two doctors team. And the moment there is a medical emergency, they panic, and that too happens all in front of the patient and their family. And non-availability of physician or anesthetic during the procedures, complexity. So basically the resource crunch, particularly the men, material, equipment, and lack of training makes things worse. So how do we go about? So being prepared for medical emergencies is not just about saving lives, it's also about giving hope to those who need it the most, because we deal with life and sight. So during emergency, every second counts. So every life matters, and every effort to be taken to make a difference. So the first step is do not panic. So we all have forgotten general medical care once we come to a specialty practice. So as a doctor, we are all already equipped with dealing with emergencies. So medical emergencies, first thing is don't panic. So we'll go through a few topics in this instruction course. So basically what emergencies can happen in eye centers and how to prepare, how to sense and save a sinking patient in eye care centers. So we'll deal with few cases. So this is the first case, a 35-year-old lady come for incision and curettage for chalazion. And generally we do give xylocaine test dose for these procedures. And after the injection, she complained of itching and suffocating sensation. So on assessment, so patient was awake, oriented, the breathing has become fast, and there was hoarseness of voice, and these were the vitals: tachycardia, tachypnea, and 85% oxygen saturation, and the BP was going down. So these are the hints to diagnosis: sudden onset, secondary to a trigger, that is injection, particularly xylocaine test dose, which is known to cause anaphylaxis, and patient presented with hoarseness of voice and was really acute with a sense of impending doom. So why is it anaphylaxis? Because anaphylaxis happens after this trigger factor. So you need to be aware of this. This is acute, potentially fatal, and this is the classic form. If there is prior sensitization, it follows after an acute event. So there's no need for investigation. You have to act straight away. Anaphylaxis is a clinical diagnosis, and investigations are not going to be helpful in this acute setting. So how do we recognize? So we probably, if you have already experienced in your medical college days or in other centers, you can easily recognize it. And sudden onset of signs and symptoms, and within minutes it happens. It might happen after a few hours also, and it affects the entire body, and a lot of symptoms happen, not easy to recognize. So there is a dilemma whether to give local anesthesia, test dose or not, whether it's mandatory or not. There is no standard guidelines, but if you are exposing the patient to a large dose of injection, better to have a test dose done, and also ask for allergy to preservative. So because there is a cross reaction among the local anesthetics. So you have to do a risk assessment, whether you are going to use lignocaine or sensorcaine. So initial steps in the management basically protect the airway. This is a key intervention, and adrenaline injection along with a cocktail of hydrocortisone and injection avil. And also support with oxygen, cardiac monitoring, and you need to have the IV access and position the patient comfortably in the same place with legs elevated. So this is another patient who came to the hospital for counseling and reception. Appointment with the doctor is scheduled. She was dilated for cataract assessment, and after 10 minutes she became restless. So he went to the reception. She's made to wait politely by the receptionist. So suddenly presented with classical symptoms of cardiac arrest: chest discomfort, sweating, upper body discomfort, nausea, shortness of breath, and giddiness. So this is a classical sign of a myocardial infarction. It is a medical emergency. Code blue was called. So our staff recollected their training and activated the code blue. And so patient was positioned, and we stabilized the patient and transferred to the nearby hospital and cardiac ambulance within 5 to 10 minutes. So third story about a 50-year-old gentleman waiting in the OPD, well-controlled diabetes because of a regular patient, so we know the history, with cardiac dysfunction, and suddenly become agitated and starts sweating profusely with tremors. So what do you do? And falls to the ground with hands on his head and sweating. So since we know that patient is a diabetic, we did a CPG, capillary blood glucose, and took a ECG as well, and stabilized the patient with monitoring the vitals, and stabilized the patient with the blood sugar. The blood sugar was 62 milligrams, and so oral dextrose, IV dextrose, and glucose in all forms was given. Patient monitored in the ward, recovered, and then sent to the physician for opinion and follow-up. The fourth story, during the surgery, 89-year-old male posted for cataract surgery. It was a dense cataract nuclear sclerosis. Patient was very anxious. The BP has gone up to 110. All types of local anesthesia given. Still, patient was in pain and became agitated. So what to do? We have a anesthesiologist always with us during the surgery. He was checking the monitor, and at some point he had to intervene. He gave IV midazolam. Patient settled immediately. The BP came down within 5 to 10 minutes, and under monitored anesthesia care, we proceeded with the surgery, and the post-op period was uneventful. Patient was discharged as a daycare patient. So debriefing, you all know medical emergencies such like this can happen anytime, any day, in any center. And these are some of the common emergencies, daycare centers: hyperglycemia, anaphylaxis, particularly after FFA to the drug. And the asthma can exacerbate it because of the anxiety in the pre-op state area. Seizures can happen, impaired shock or consciousness, then cardiac arrest. So there are many ways of being sick and defining critical illness. Our staff have to be prepared for it. And so apart from having intelligent people, we also need to have intelligent reception with the facilities for triage and enquiry. It's important that we teach our staff to check the pulse and vitals. And if we are the only doctor, ideal to have a CCTV to monitor the reception area. And we have to train our staff, because most of our staffs are either trained in optometry or in as paramedical people or as vision technicians. So we need to train them about identifying identifying the vital signs, and also the respiratory rate, and also ensure that we notice the saturation rates. And we also need to know our patient, particularly old patients with a lot of comorbidities. We need to make it a point to note in the case record their age and medications. And we need to have some gut feeling if there is a problem in the reception or waiting area. This risk assessment is very, very important. If you don't have an anesthetist, we can still follow their guidelines on patient classification, AIOC2024. So if you are going to take the patient on a local anesthesia or topical or infiltration anesthesia, safe to take patients under AIOC1 and 2, and all others we need to have support from the physician and the anesthetist. So always keep an eye on the high-risk patient group, elderly patients, patient with comorbidities, wheelchair-bound patients, and referred from other clinic with like patients with CKD. So risk to practice. So there is always a risk to practice, the surgeon, as well as a financial risk because of not adhering to these standard procedures. And it's always better to have more number of certified BLS staff, train them and keep them with us. So some point of time they will help us. And so this is very, very important, noting the history and see if there are any red flags during examination. Assessment, not only ophthalmic assessment, general assessment is mandatory, and intervention at the right time, at the right place, whether to treat the patient there itself or transfer the patients. And we also need to communicate with our team if there is any learning. So how are our patients now? The first patient doing well was admitted in the ICU for observation for 6 hours, monitored and was sent home. Our team did a job of documenting them well. The second patient who suffered a cardiac event recovered in ICU, was treated medically. Cataract surgery was done after 6 months. The patient is happy because we literally saved their life and gave a wonderful feedback. And our team was very happy that they were able to save not only the life of the patient, but also gave back good vision. So nothing can replace identification and risk assessment at the right time. So skills and knowledge how to be used to restore sight and hope in our patients. So thank you so much. The important benefit of having a trained team with basic life support is the ability to save eyes as well as lives. So thank you so much. We can take questions if there are any questions.